Good morning. My name is Bill Baker. As you well know, the Society for Vascular Surgery has initiated a series of interviews so that the Society will have an oral history of not only our society but of vascular surgery in general. The interviews are being conducted with notables, if you will, in vascular surgery, and today we have Dr. Tom O'Donnell from Boston. Tom is an accomplished surgeon. He's a world's expert in venous disease. He has an interesting background in that he's been an administrator. And before I tell you everything, why don't we just say hello to Tom and welcome him and let him tell us his story. Tom, good morning.
Thank you, Bill, and thanks to the Society for Vascular Surgery for producing this oral history. And as I said, I'm honored to participate in a small way.
Well, you're a Bostonian. You were born in Providence, not too far away.
That's right. My father and mother lived in actually Dedham, Massachusetts, but my mother had, strangely enough, compared to most people, more confidence in the obstetricians in Providence than she did in Boston. So she went back to Providence to have me delivered. So I'm, I guess, legally a Rhode Island resident, per se.
What did your parents do growing up?
My father eventually became a high school principal. He was in education. He taught history at Dedham High School and was a coach. He was a very good college athlete at Colby College in Maine and actually was a little All-American football player. So during that time, there weren't a lot of jobs available, so he went into teaching, which he loved, and he coached sports, and then he did a lot of refereeing of football games, and this was a way for a son and father to bond. I would go off on a Saturday with him, take these trips and watch him ref. It was a great experience, except for several times when the fans got a little excited about how we called some of the plays, and we were locked in the locker room for a while until the police came. But it was a bonding experience.
Oh, and you have brothers and sisters?
I have one sister who's 4 years younger than me.
All right, and so you then went to high school locally.
I went to high school at a prep school called St. Sebastian's. My father then was the principal of the high school, and he felt that, gee, if you do well, they might say that your father's pulling the strings. So I went to St. Sebastian's in Newton, and there was some very important experiences that influenced me to go into medicine. The number one experience was I fractured my leg playing football, and I was taken care of by an orthopedic surgeon by the name of Joe Dorgan, who was at that time the team physician for then the Boston Patriots, not the New England Patriots. And he was such a role model. He, sort of like you, Bill, he had tan, always came in just off the golf course, was very kind, and to a young guy said, gee, I would like to go into a profession like that. So he really put in my mind the idea of becoming a doctor. One of the little interesting vignettes about Dr. Dorgan, and it's not violating HIPAA because it's been told a number of times, is Joe came back to me many years later and said, I've got an abdominal aortic aneurysm, and I want you to treat it. So I had the honor of operating on him, taking care of his abdominal aortic aneurysm as payback for him nailing my hip.
What goes around comes
around, right.
All right, then you went from there to Harvard.
Right, I went to Harvard College. The football injury knocked me out of some of the competitive sports that I was playing at the time, which was baseball, hockey, and concentrated in golf. So I went to Harvard. Majored not in biochemistry, but in classics, Latin and Greek. While at Harvard, besides having a good time, I was an editor of the Harvard Crimson. And an editor, they have multiple editors, but it was an extracurricular activity that kept me busy, as well as translating Greek and Latin.
I must assume that somehow you found time for biochemistry and all the rest of those.
At Harvard, yes. At Harvard, the requirements were inorganic chemistry, physics, biology, and then the course that determined whether you were fit for medical school was run organic chemistry was run by a professor by the name of Louis Fieser. And if you were able to get a B or better, then you probably could make the grade into medical school. But if you didn't, that landed a lot of people into hospital administration or some other job.
So obviously you did a B or better,
Right.
and you then went to medical school at Tufts.
Tufts Medical School, which was down in Boston. There were several of my classmates from Harvard who also went there. There was 8 of us. And went through Tufts. Great experience, although having majored in the classics, the concentration on science in the first year or two required a little extra effort, but managed to get through Tufts AOA and actually was president of my class for 3 years there. But had a good opportunity to see surgery close up because I did my surgical rotation at the Tufts service at Boston City Hospital, which was always exciting. And this further emphasized the fact that surgery was what I should pursue.
Any particular heroes at that time that you can recall?
Well, Irwin Hirsch, who was still passed away recently, was from the Navy, came back, and we saw a lot of trauma surgery at Boston City Hospital. He was very impressive and was a good influence. And my chief resident was a fellow by the name of Ralph Froyo, who's still practicing in a wound center, and he was very influential.
Then from then you went to your residency, internship and residency.
Yeah, I was lucky enough to be selected by Bill McDermott to go ahead and join the Harvard 5th Surgical Service at Boston City Hospital. Dr. McDermott was an individual who was unique among, now as I look at it retrospectively, departmental chairman. You could call him up at night and shoot the breeze about politics of Boston City Hospital, of which there was plenty, or problems. He was a major influence in that area of medicine. I first met George Clues in my second year of residency. That is Alex's father, and we'll subsequently talk about him, but he became a real mentor. Intensive care units were new at that time, and I got involved in the intensive care unit, was fascinated by the sort of circulatory dynamics, and Clues was very supportive of that. And I left after my second year of residence. Like many people, I had a partial berry, and I went to Beaufort Naval Hospital in Beaufort, South Carolina, which is the major support hospital for Parris Island. I was scheduled to go to the hospital ship Repose, but they decommissioned it, and my opportunity was to stay there for 2 years, which was a very great experience. I operated the first year, and then since I decided to stay there, I suddenly was transformed into an internal medicine physician, taking care of a lot of flag officers on the offices floor.
Well, you also did some other things at Parris Island.
One of the interesting aspects of Parris Island, if you're a Marine, is how hot and humid it is. And I had noticed that a lot of the Marines were suffering heat injuries. So I started cataloging the number of heat injuries and their types, as well as other injuries sustained during recruit training. And sort of did an epidemiologic study and correlated the incidence of heat injuries with atmospheric conditions, wet bulb, globe temperature, and the time of day. And then did a more in-depth study of circulatory dynamics in people with heat stroke. They inevitably would come in at 4 o'clock in the afternoon. We just would have finished our day, and I was lucky to get a cardiac output machine. At that time, we were using indocyanine green to measure cardiac output. Put a radial artery catheter in, inject, and measure cardiac outputs in these Marines for 24 hours. And this work, working with George Clues as a collaborator, ended up as a publication in the New England Journal of Medicine on the circulatory stresses of heat stroke. The more important aspect was that the epidemiologic data helped to change how Marines were trained as far as when they could exercise. I had worked for 2 weeks as a reservist during my second year of residency down at Naval Medical Research Institute in Bethesda. And I sent some of the data to colleagues up there, and they said, wow, you ought to really present this. So I presented it initially to the naval physicians up at Bethesda, and then they asked me to present it to the Commandant of the Marine Corps. And so I was here presenting, and those familiar with the military, little guidon ribbon, where these guys had a full chest of ribbons, this young lieutenant presenting what I thought the Marine Corps ought to do in training, and to their credit, they modified entirely their recruit training dictums. They restricted exercise at certain wet bulb globe temperatures, which are much lower than they previously had. And I have admiration beyond belief for the Marine Corps,
Well,
as this pin here shows.
that's good. Well, it's always nice to have somebody who has a positive experience.
Right,
There's too many negatives.
right.
All right, so then you went back into training after that.
I went back to Boston City Hospital, and that was my PGY 3 year. And all of us, as probably during your training, you went and did some research. I was fortunate enough to work with George Clues, spend a year in the Sears Surgical Laboratory, and we were looking at the circulatory effects from sepsis, and we used as our model a pig, little pig. You could tie off the cecum, and it would produce, much like humans develop, peritonitis. In addition to looking at the circulatory dynamics, we were looking at intermediary metabolism, and I was able to carry the research on because of another stint in the research lab. And what eventuated was explaining why people waste away when they're septic. The concept was you have 3 fuel sources: carbohydrates, fat, and protein. Because of circulating insulin levels, you're not able to unlock your fat or your carbohydrates, so the individual uses protein as a source of his energy fuel deficit. And this was actually written up and managed to win the Academic Surgery Research Prize. And then we were able to reproduce it, not only in pigs, but in humans subsequently, and presented at the University Surgeons.
Fascinating.
But what I realized, however, is I worked with a fellow by the name of George Blackburn,
Yes.
who's renowned, and I said, I don't think I'm going to spend the rest of my life telling people what type of hyperalimentation mix to give. And I was fortunate enough to work with George Starkey, who was a thoracic vascular surgeon, saw my first aortic endarterectomy, and then was exposed to 2 people, John Lynch at the VA hospital, who could take the most indelicate surgeon through anything. He was just a master craftsman. He always used to say, I don't think we want to do it this way, but we can handle it in case we do. And then a fellow by the name of Frank Wheelock at the Deaconess Hospital, who was a very demanding individual who taught me there are no compromises in vascular surgery. So those people influenced me really to think about vascular surgery as a future endeavor.
No compromises, eh? Don't you wish that lesson was universal?
That's right. You usually get burned when you try and compromise in vascular.
All right, then you stayed there for your chief residency.
I was chief resident, and at that time, due to politics, the mayor of Boston kicked Harvard and Tufts out of Boston City Hospital. So my Harvard moved to the New England Deaconess Hospital, and subsequently, 10 or 15 years later, the Deaconess fused with the BI. But we were at the Deaconess and rotated through the Deaconess, the Manchester VA Hospital, working again with John Lynch and doing a lot of vascular surgery, a lot of carotids. And at the Deaconess, had an opportunity to spend a couple of months with Wheelock, month with Dr. McDermott, who did a lot of porticable surgery work, and Neil Sedgwick, who was at the Leahy Clinic, who was a general surgeon, but a master craftsman. And at the end of it, I had applied for a vascular fellowship, and you well know, and Jim, that there weren't a lot of vascular fellowships around at that time, and I wanted to stay local, and we finished in a staggered way. We finished in September, and I secured a vascular fellowship for the following July with Clem Darling. So I had some space to fill, and George Clues, in his tremendous mentoring way, said, well, I have a friend, John Kimmeth, who I share a sailboat with. Why don't you, we'll get you a job as a lecturer at St. Thomas's Hospital in London. So I had an opportunity to spend a great deal of time over there. And again, I look back on it, that experience changed my life as far as what I thought I would like to do in clinical research. I might say a little bit more about George Clues. He was a unique mentor. You would work with him in the laboratory, and then he'd say, his wife would be down in Falmouth, and he lived out in Dover, had his own tennis court. He said, let's go over and play tennis, then we can have a steak afterwards. He really took me under his wing, sort of like a father in vascular surgery. So I deeply respect what he did for me.
Now, so then you went to England.
I went to St. Thomas's, which was a very interesting experience. Arrived on a Friday. They had a party. We partied, and then they did an operation the next day, AP repair, and they said, gee, why don't you do the bottom end while you're here? And that was my initiation to St. Thomas's Hospital. And it was more oriented to research for me. I was brought over ostensibly to work with Professor John Kimmeth on lymphatics, and what our experiment consisted of was dissecting out lymphatics in rats and injecting BCG into the lymphatic, and these rats were infected with a rabid VX2 tumor. So it was to see how intralymphatic delivery of a substance could affect the growth of a tumor. While I was doing that, I also did a lot of clinical lymphatics. I ran into the other professor in the department, Norman Browse, very young, aggressive vascular surgeon. And he was doing a significant amount on venous disease. And he really helped me get involved in doing some clinical studies on venous disease. Ironically enough, at that time, a fellow by the name of Kevin Bernand was also in the research lab, and he and I teamed up to look at patients with advanced chronic venous insufficiency, venous ulcer, and in particularly answering the question, does treatment of the perforating veins make any sense on the clinical course? And we did two trials. One, a retrospective study of patients who had had perforated treatment 5 years previously, and divided them by the presence of deep venous disease on phlebography versus no deep venous disease. And what we saw was ulcer recurrence was much more common in the patients with deep venous disease, which hadn't been really recognized too much at that time. And then we did a prospective trial of 120 patients with various forms of venous disease and looked at their ambulatory venous pressure patterns and how they related to before surgery and after surgery. And again, treatment of the saphenous was the most important thing to do to affect the circulatory dynamics in these patients. Treating the perforators, particularly if they had deep venous disease, did not make much of a change. And subsequently, in the ESCAR trial, 30 years later, that was the clinical conclusion.
As I recall in your presidential address to the Venous Forum, you addressed that issue one more time.
Right, right. It's a recurrent question, and truly hasn't been solved because there hasn't been the correct clinical trial to isolate out the effect of the perforators with long-term clinical follow-up. There's been some hemodynamic studies. Most of the 2 randomized controlled trials have combined treatment of the saphenous and perforators versus conservative treatment rather than dividing them.
When I said these gentlemen changed your life in terms of what you wanted to do, is they diverted your interest into venous disease, or were their personalities that?
I think it was a combination of both. First of all, Professor Kinmuth showed me how a academic unit should be organized. And secondly, showed me about lymphedema, which we certainly, in my surgical residency, had no exposure to. And Norman Browse taught me a lot about venous disease. And it would become important because when I came back to Boston, I would be one of the younger vascular surgeons in an academic center in Boston. And you needed something to de-differentiate yourself from the other famous surgeons at that time, like Clem Darling, John Manick, and others. And so it gave me an area, clinical area to focus upon.
Then you came back and did your American fellowship.
Spent a
Dr.
year with Clem Darling, who was a master, superb technician. He would teach you how to get out of trouble if you got into it. And he had a very high volume aortic practice as well as bypass. He had worked with Robert Linton and then took over from him, and really allowed you to go ahead and do the surgery. The general setup was that you would take one of the residents, usually PGY2, through the aortic exposure and then call him at that point, and he would come by. It was a way of integrating the vascular fellowship with the surgical residency at the Mass General so it didn't detract from the surgical residence experience.
Sometimes easier, sometimes harder to do,
That's
particularly in
right.
that era.
Right. Well, luckily, I must say that I was fortunate enough to work with a lot of good young resident surgeons, and they did a good job.
That's super. So he would come in and help you do the aorta, or
After a while,
or
yeah.
you would help him, or
Yeah, right.
whatever.
The
it turned out to be.
usual training paradigm.
Yes, and at that time, vascular surgery fellowships were not world-renowned for the volume of surgery.
Right, but he had a high aortic volume. I think I ended up doing 60 cases or more.
What kind of a individual was he besides being just a good surgeon?
Clem was a character. He was very expressive. One of my favorite stories would he would come into the OR in the summer and say it's too hot in here, and strip down to his boxer shorts and have them gown him with his boxer shorts on. He was, he just was a funny guy, and if you didn't do it the way he wanted to, he let you know. He had a scrub nurse by the name of Carlina, and if things weren't going well, he'd say, "Carlina, come up here and hold the retractus. You go down there." You know, it's like being put in the corner in the sandbox. So he was a real character.
So anyway, then you stayed in Boston, and
I was looking around for a job, and one came available at Tufts, where I'd gone to medical school. So I went over and joined 2 former presidents of the SVS, Ralph Detteling and Alan Callow. And I was the junior man in this rotation. And Alan was very glad to see me because he said then he could take less night call, and this was a great relationship. So I went to work there at Tufts, eventually became head of the vascular laboratory, and sequentially through the various administrative positions.
tell us about Ralph and Alan. What are they like as individuals?
Ralph was a very kind, thoughtful man. He had been chairman of the Department of Surgery at Tufts and then stepped down to a staff position. And despite that, he went ahead, very kind to me, very helpful, always providing academic advice. Alan is a very dynamic individual. He became an admiral in the Navy and went by the nickname the Admiral. Alan had probably one of the largest carotid practices in New England, and I was able to learn a lot about carotid endarterectomy from him, and it became certainly an interest of mine. Had a high volume practice. I mean, it's just incredible. You do 3 or 4 carotids a day, 2 days a week.
Amazing.
He trained certainly members of the SVS like David Rosenthal, David Kosman. They all had worked during my early years as a staff there. They were fellows with Alan.
Then you went through the ranks, and you either by hook or crook or some other method, you became chairman of surgery.
Well, what happened was I was recruited there originally by a fellow by the name of Dick Cleveland, who was a cardiac surgeon, very good cardiac surgeon, and he thought that as time went on, that as he retired, that I'd make a good chairman. I had been chief of vascular surgery, and so I then became chairman for 2 years before I took on a new job, new assignment.
How was that being chairman over your peers, if you will?
I don't think it was a problem. It's like anything in life. It's all about interpersonal relationships. You have to satisfy people's needs, and for surgeons, it's that they are being compensated for their work in an adequate manner, and you have to sort of explain why they're being compensated as X and Y. One of the interesting things is that each of the surgeons was on a separate P&L setup, and that was a way of showing, here's what you did, here's what you're going to get paid. Certainly there were cross-departmental subsidies, and the hospital helped out in areas like transplantation, which was difficult for them at that time to bring in the clinical revenue to sustain their salary.
And then you said you were tapped for another job.
I was chairman, and Tufts, then New England Medical Center, was going through some stressful times. The healthcare market in Boston was like the last man standing without sitting down in the chair, musical chairs. Everybody had allied with another hospital system, Partners, St. Elizabeth's, and we had lost our Harvard Pilgrim contract, which is a big insurance company, and they had taken it away from Tufts, so it was a major hit as far as a revenue source. Doctors were leaving, and I had become involved in the physician practice group and had asked to sort of become the leader in that, and the trustees had met. They had asked the CEO, who was present several months beforehand, to leave, and we had a temporary CEO who was a venture capital individual, one of the trustees who actually almost put a for sale sign on the hospital. This upset a lot of the trustees, since the institution was one of the oldest in Boston. It's found in the Boston Dispensary. Paul Revere had been a patron. But anyway, the lead trustee asked me to meet with him, and he said, we're looking for a CEO, and we want you to be the CEO. And, totally floored me. I had not taken any business courses at Harvard. And so I actually sought the advice of my sons, who are subsequently pretty schooled in business, and after a lot of thinking about it, said, it's like, who wants to shoot the ball? Larry Bird always wanted to shoot the ball. If you're going to point someone internally, I want to be that guy. So I became the CEO of New England Medical Center and president. And our tasks were, as I outlined, first to get the Harvard Pilgrim contract back. And to do this, we launched a pretty heavy-duty political campaign. and were helped immensely by then State Senator Stephen Lynch from South Boston, who really pushed it to the point of actually having a bill proposed where hospitals cannot be excluded from insurance contracts. Then Senator Lynch is now the representative, U.S. representative to the House of Representatives. But he was extremely helpful in getting it back from Harvard Pilgrim, and there were some very contentious meetings in the State House about this. I learned about lobbying at that time. So we got the Harvard Pilgrim contract back. We then looked for merger partners and went through a lot of processes, interviews with HCA, with St. Elizabeth's, and with, at the last minute, a system from Rhode Island called Lifespan. And in talking with fellow physicians, they were concerned about HCA because it was a for-profit. They didn't see how that organization would bring patients. And in the end, Lifespan seemed to be the best option, so we merged with Lifespan. At that time, Lifespan was headed by a CEO by the name of Bill Krakis, with whom I formed a bond. He was a very honest individual, and we became part of Lifespan. And that helped us, our strategy, which was based on centers of excellence, transplantation. We were therefore able to get the liver transplantations from Providence and eventually cardiac transplantation. Complex cancer care, cardiovascular has always been strong, and eventually we recruited individuals to do bariatric surgery, but the real major ones were cancer, cardiovascular, and transplantation. That was a happy marriage for a while, but with changes in personnel, it became less of a happy marriage. And what happened was we felt two areas were not being paid much detail. First of all was our insurance contracts. And secondly, we felt the corporate charges were becoming excessive and growing out of proportion to the service that was provided. And these corporate charges on the expense side can amount to $40 million. So if you're looking to cut an even bottom line, then dealing with those corporate charges were important. And on the revenue side, if you're not getting paid the appropriate amount for a service, then you're going to lose it on the revenue side.
So it sounds like you became a green eyeshade person in this.
No, you have to be a green eyeshade person. And one of the things I realized, chief operating officers are important, but the most important individual in the organization beside the CEO is the CFO. And I spent a lot of time with our CFOs learning about hospital finances and relying on them and on two lead trustees, first George Carmody for the first couple of years, and then a individual by the name of Mal Sherman, who was a very astute financier. And they sort of taught me along with the CFO, and we worked together as a team.
Let me ask you, how did you balance your past, which was academic surgery, with this newfound job? And was there much discussion at higher levels of how to maintain academic excellence within the institution?
There sure was. One of the things in the Department of Surgery we tried to certainly push is the requirement for academic excellence. As far as the...
what do you mean requirement? For the faculty?
For the faculty. Sorry.
So that you wouldn't, an assistant professor would be hired with certain academic goals?
Certain academic goals, expectations as far as productivity clinically. As opposed to the Department of Medicine, it's very difficult for most surgeons to be able to do two things, clinical and secure a NIH funding. So we try to provide funding to them to do the research. But most of the research was clinical. For the institution as a whole, we appointed a chief scientific officer, Michael Mendelson, who was interested enough the vascular biology area And he really brought in a number of major grants looking at the biology of the vascular wall. His major concept was the effect of estrogen on arterial healing. And I actually worked a little bit with him, but that and the cancer area were really major academic pursuits.
I noticed your name was on a grant with him.
Right.
So what was the conclusion? What does estrogen have to do with arterial healing?
Well,
Am I in trouble?
No, you're not in trouble. It's actually been changing. You look at the animal experiments, and they would suggest that estrogen is very important in modulating the response to injury, i.e. positive. Some of the clinical trials, however, suggest that estrogen, as far as development of atherosclerosis, is adverse. And then there's been some conflicting trials recently which would favor that it's beneficial. So the jury is still out on that.
I don't have to go home and worry.
You don't have to put on an estrogen patch, no, Bill.
Oh, good. You also worked with Dr. Kaplan, the neurologist?
Dr. Kaplan has a long-term interest in carotid disease, and we had a research grant, but more importantly, we collaborated in the management of patients. One of the good aspects of the neurology team at Tufts New England Medical Center, Lou is now over at the BI, is that they had a positive attitude towards the role of surgery in symptomatic patients, and even in selected asymptomatic patients. So it was not, we're going to hide this patient from the surgeon because we don't want them to have the scalpel in the endarterectomy. They worked collaboratively with us, and one individual in particular who passed away too early in life, Mike Pessin, who had trained at the Mass General, was very aggressive in recommending patients for carotid endarterectomy. So,
And other research grants you've had were with the Admiral, I think.
the Admiral was an amazing guy in that, I don't know what age he was, all of a sudden he went into real basic science research and secured an R01 on healing of arterial blood vessels, more importantly prostheses and seeding of endothelial seeding of prostheses. And he worked with a cardiologist at our institution by the name of Peter Libby, who was one of the principal investigators on the grant. And we had a series of papers, experiments, but the conclusion is it's difficult to seed prosthetic grafts. I think we learned more about the response to injury in the arterial wall than we did synthetic graft seeding.
Jumping around a little bit, you also wrote a paper one time about the results of carotid endarterectomies in academic centers versus non-academic, and compared that to the costs.
That's right.
And came up with some interesting conclusions.
Well, the conclusions, first of all, we had available to us at that time data from a state-maintained database where we could look at the relative costs, hospital costs, not physician costs, hospital costs of performing an endarterectomy and taking the patient through the hospitalization. And what we found, and the reason we wrote this, is we knew the Balanced Budget Act was going to affect what academic institutions would be able to realize out of treatment of all vascular cases, but we used carotid endarterectomy. And what happened was the academic medical centers adapted by reducing expenses over time so that they could provide in an expensive institution less costly care. Reduced stay in the recovery room, shorter hospital stays. One of the colleagues who worked on that was our fellow Sean Roddy, and he wrote several other papers and has maintained that interest, and now he represents the SVS in all of the financial aspects with the federal government.
Well, I can stray even further and ask a Bostonian how medical care is in the state of Massachusetts, because I understand they have a plan that's parallel to the federal plan, if you will.
Right. What has happened in the state of Massachusetts, in theory, everybody should have insurance. They have a organization called the Exchange, which will provide insurance. And I think it's beneficial because one of the major expenses for a healthcare system is people ending up in the ER for problems that could be taken care of at a doctor's office, but yet they're still charged because they don't have any insurance, and the hospital ends up bearing the expense, and sequentially then the rest of the taxpayers and insurance owners end up paying for it. The consequences of that is that many of these plans have high deductibles or copays. So the patient really has to think about whether they want to have their varicose veins done, or what I call lifestyle modifying procedures for surgeons, as opposed to life-saving procedures. And what eventually is going to happen if Obamacare comes in, I think the same type of processes will have to take place on a national level. When you bring in a number of patients who are uninsured and there's no new revenue, you have to figure out how are we going to balance the books. And the balancing of the books, I would predict, will be somewhat on the backs of physicians and hospitals, with reduced payments to those individuals over time. The other people who are starting to pay the price is the industry. The medical device industry in the state of Massachusetts now has a tax, and it's part of the Obama plan to tax medical device companies. So they'll have to pass it on to the consumer. The problem is that everybody expects the same level of care without any more selectivity in who gets that care. The interesting response to the recommendation about screening for mammograms, it was evidence-based. They brought it forth, probably not in a well-thought-out political strategy, but the hue and cry just totally dashed that away. We are going to have to be more selective in our diagnostic studies and who gets therapy. And most importantly, as the group at Dartmouth have shown, expenses at the end of life. As we will have to face this problem either now or later, because healthcare is becoming too much a percentage of the gross national product.
Has healthcare costs in terms of percent of your budget gone down or up in Massachusetts?
They have gone slightly up, but not at the projected escalation that would have happened without this. But it's a problem, because even in Massachusetts, we've got to learn how to select diagnostic studies and therapeutic interventions.
In your presidential address, you went back and looked at the old original bylaws and the mission of the SVS. How do you think we're doing?
I think we're doing very well. I mean, it's incredible when I look back and compare when I was president of the SVS and involved with the organization to what it's become now. The reason I did that is because at that time I was in administration, and I said, let's take the administrator's perspective on the SVS. And in any organization, the mission statement drives the strategy. And so what I did was take the temperature of the organization at that time, look back on the presidential addresses from the beginning to contemporary, and looked at the evolution from clinical topics to more political healthcare training topics by my predecessors. When you looked at the early addresses, they're generally about a clinical topic, venous disease, because no one was doing arterial surgery. And over time, there was a real strong focus on training, which is a mission of our society, of residence, certification, qualification. The other thing, sorry,
Go
the
ahead.
other thing, what I realized is from my exposure to the Marine Corps, where we talk about a few good men, there were not a lot of women involved in vascular surgery, and we had to make some modifications in the way we train women. I have two daughters-in-law. Both are graduates of Harvard Business School, and they do work in addition to raising three kids apiece. And we need to we needed to change the facilities for training women, allowing them time off out of a residency, making daycare available, small things like this, so that we can, and we have, as evidenced by the women in vascular surgery today, so that we could have more women participating.
There's no question when you cut out 50% of the population, you cut out a lot.
That's right. As you point out, at that time, 50% of the graduates of medical school were women.
Yeah.
We were drawing on the men, and it was, vascular surgery is, along with cardiac, is one of the macho sports in surgery. So we needed to allow women to participate.
What's your current training program? How many years of general surgery do your trainees have and before they go into vascular?
Well, as a prelude to that, one of my jobs at SVS during my present year was to chair a group of people to look at how we could modify training, because there were two conflicting aspects of training. One, we had increased didactic load with catheter-based techniques, and then we had residents who were in hoc and wanted to get through, and it was obvious that we were going to have to extend the amount of time for vascular training. So this group came up and examined a number of paradigms, and the one they favored was 4 years of general surgery and 2 of vascular, and you could go off 4 years in the plastic, 4 years into cardiothoracic. Someone called it general surgery light. That didn't really take hold, and strangely enough, the one that eventually did take hold was the 5-year straight surgery, which was not really favored. Our current program is, we do not have a straight 5-year. We have residents who come in after 5 years of general surgery and then do 2 years of vascular fellowship with us. And it's all clinical. There is some clinical research done, but it is not like what we had in the past, where they would do a year of research and then do 1 year of clinical. Now it's an integrated program where they do catheter-based techniques during their first year. They work with me in venous and others in venous disease. They do outpatient wound center, and on weekends, the first year fellow would cover, obviously, emergencies, and then the second year, a lot more open surgery, as well as the big-time catheter-based techniques. So it's a 2-year program.
They get much time in the clinical laboratory, diagnostic laboratory?
You mean the vascular lab?
Yeah.
Yes, they do. During the first year, they read all the vascular labs, and the way that we've organized a problem in any institution about emergency duplex scans for DVT is the fellow makes the decision whether the patient deserves it. And the fellow comes in to do the study, she or himself, on weekends and nights.
So you have the vascular fellow make all these weekend and night decisions, and you spare the vascular technologist this onerous chore.
It has two purposes. One, as you said, it spares the vascular technologist, and it's a costly endeavor if you're going to have people on call. And second, it makes particularly the residents in internal medicine think about whether they really need this study at that time, or the ER physician, so that it has a twofold benefit. Also, the fellow learns how to do a duplex scan for venous disease, which I think is pretty important.
The other thing which I think you've written about is that there are other ways to treat somebody with a suspected DVT besides putting a Doppler on their leg. You just treat them with anticoagulants.
Well, you can, many institutions give the patient Lovenox and say, come back in the morning and we'll, if you're negative, you've had one shot of Lovenox. If you're positive, we'll continue on. Yeah,
Yeah.
That's one other strategy.
Where
But
do
there's
you-
an educational aspect.
Yes. Where do you think vascular surgery is going?
I think vascular surgery has embraced the catheter-based techniques, and as I look at our institution, it's very infrequent for the initial treatment of infrainguinal disease to undergo an open procedure. So we definitely have shifted to a more catheter-based technique. We are certainly doing a lot of that in the aortoiliac disease. It's very unusual to see an aortofemoral. It's split as far as treatment of aortic aneurysm, endovascular versus the open technique. But again, most of the data shows there's really no benefit to EVAR over the open as far as long-term survival and other aspects. Where I don't think we're going to see catheter-based techniques become superior, predicting, is in carotid disease. Just having done a recent review of asymptomatic carotid disease for CMS, one of my other little duties is I work in an AHRQ evidence-based practice center. And we amass all of the randomized controlled trials, do a systematic analysis, and we completed one for AHRQ on asymptomatic carotids, comparing surgery versus catheter-based techniques versus medical management. And what has changed dramatically is the better medical management now. And I was a little shocked to hear Wes Moore, which I agree with him, that perhaps medical management for a greater percentage of patients with asymptomatic carotid stenosis might be the correct option. And the deflection point correlates with the introduction of the statins. When you look at, I don't care what cardiovascular mortality, peripheral, carotid, amputation, the death due to cardiac causes is reduced markedly after the introduction of statins. So aspirin, better hypertension control, and statins has altered the course of the asymptomatic carotid patient. So it becomes an individual decision who gets it, and perhaps the work on the characteristics of the plaque, the asymptomatic plaque, may be a way of selecting patients who should get surgery rather than medical management. So I see that's where surgery is going, vascular surgery. It's going to be more catheter-based, more and more catheter-based.
On a different topic, what's your handicap in golf now?
Well, as a fellow golfer, sports for me and my family are a very important outlet. And I'm a 14 handicapper now. And it's a major form of recreation and an outlet for me. I played in our member guest last week on a club called Hyannisport on the Cape, where I was fortunate enough to be president for 4 years of that club. Jack Kennedy played there, President Kennedy. And I'm playing this weekend at Newport in a member guest. So my summer consists of operating during the week and then going ahead and playing some member guest golf or tournaments someplace. I had to give up tennis, which I enjoyed playing against Jim Yao and Gene Stranis, because back and knees became a little balky, so golf is a good substitute.
Well, Tom, welcome to Chicago.
Jim, thanks for inviting me. It's very exciting to get out here and see Northwestern again. You had invited me back in the 80s as a visiting professor, so it's nice to see how the medical center has even grown further than it was then.
Well, just a few questions. I was in St. Mary Hospital in 1967. I enjoyed very much over there. I know that you were in St. Thomas Hospital before. I just want to ask you about John Kinman. We never had a chance to talk to him.
John Kinmouth, as I said to Bill earlier, really was a role model for how to run a department. Everything was organized, structured. What I was impressed about was when his registrars would present at a meeting, their presentation would be rehearsed for 4 successive surgical meetings, and modifications would be made. And I said, gee, that's not my experience. You know, you get it done, professor may see it at the last minute. And Kinman says, they are not representing themselves, they're representing the professorial unit at St. Thomas's Hospital. And he took pride in his work, pride in his fellows. So he loved to take care of lymphatic patients. It was very funny. I remember doing a few cases with him, and we were doing a fem pop, and I kept waiting to see when he was going to come in. He finally showed up when everything was dissected, and he said, Tom, you should go down and do the popliteal. That's the easier of the 2 anastomoses. I'll do the femoral. He was a great man, and his wife Kathleen, who subsequently married Richard Warren when John passed away, became a good friend.
Right.
Just a gracious family, and did more than they had to when my wife Carolyn and my 2 boys were over there.
Talk about lymphatic. It seems to be not much new about that area. What was your thought about it?
Well, lymphatic treatment is truly probably where venous disease was a while ago. There's only conservative treatment. The attempts at doing anastomoses to veins or to lymph nodes have really not borne much fruit, because the majority of patients we have are secondary lymphedema, where they have little wispy lymphatics, which are difficult to treat. So the principle is good skin care and compression with various pneumatic devices. And there's some newer compression devices. I originally did some work with an Israeli surgeon who had developed a lymphopress, and we had written about that. The advantage was it was a sequential unit which would vary the pressure and milk the fluid out of the leg. There are some other devices now called the FlexiTouch, which tries to mimic, if you will, manual lymphatic drainage with lower pressures and more rapid cycles. But that's really the principal treatment. I don't think, other than extirpation of fatty lymphatic tissue in the leg, surgery per se is going to play a major role.
That's right. You also work with Norman Browse. Tell us about him.
Norman Browse, as I said earlier to Bill, was a major influence on my life. First of all, he got me involved in research that was really good for me to work with him, but also I think was important, and introduced me to Kevin Bernard. But like Kinmouth, he took an interest in the individual and would work with him on authoring the paper. I would write a paper and Browse would say, wrong, you're too complex. Simplify, simplify. He was, if you will, the Ernest Hemingway of the written scientific product. He wanted everything simplified. So for someone who had studied Latin and Greek and used elliptical phrases, it doesn't belong too many times in scientific writing. Simplify with simple sentences. So Browse really taught me to write a scientific article, as well as helping with his research. He was not recognized, but he was an excellent surgeon. He had a tremendous record with carotid endarterectomies at St. Thomas, and used to practice in the dog lab his techniques. Obviously, then he was recognized for his leadership and became head of the Royal College of Surgeons and was knighted by the Queen. But when he was a young guy, it was very interesting. We would make rounds, as you remember. And it's not like rounds in an American hospital. You would have nurses, the sisters, all of the residents, all of the medical students would troop together to see patients at the bedside. And what I found different were two things. One, the willingness of a British patient to just take what the doctor says. If we're going to take your leg off, we'll take it off. They were very stoic about it. But secondly, the surgical house officers in the UK did not question authority. And for me, coming from the United States, you know, Professor Kidman might say something. I'd say, well, gee, that doesn't make sense, Professor. Why don't you do it this way? The residents would look shocked, etc. But it's a different culture that we are brought up in. It's perhaps changed, but at that time in 1970, it was very rigorous as far as who got the talk.
I remember Norman Browswell in all the research meeting. He always the one that really take you apart, period.
That's right.
Absolutely.
I called him Doubting St. Thomas after the biblical reference to the apostle St. Thomas, who didn't think it was Christ had risen. He had to put his hand in the wounds. But Norman would doubt anything. And at the Surgical Research Society, I'd hate to be the surgical house officer who presented a paper when he got a hold of it. He was very tough. And subsequently, Kevin Bernard was cut out of the same mold. He followed and would cut people
right.
up at meetings, you know, all for scientific purity.
You know Frank Clarkett?
I ran into, they called him Ace. I ran into him because he had the unit and did not have a very close relationship with him because I was really more in the professorial unit. But
Yeah.
he was certainly, as we look back on discoveries in venous disease, a major influence in the thought process. And Crockett studied with Linton at the Mass
Right.
General and got a lot of concepts from Linton, which he applied when he went back to the UK.
Well, you have a very good training in lymphatic and venous disease.
It stood me in good stead. I think what's interesting is the evolution of venous disease treatment compared to lymphatic. When I entered practice in Boston, all you had is ligation, stripping, inferior vena cava devices, subfascial ligation, and now we have totally gone minimally invasive with ablation of veins and with endovascular treatment of iliac obstruction. So it's been a birth of technical approaches to venous disease, which we didn't have in the past. And, you know, it has its challenges, though.
What's your opinion on those venous ablation technique?
My opinion on venous ablation technique, since I do not a huge number, I do about 150 cases a year between DETA medical associates and Tufts, that it is a dramatic improvement over ligation stripping. The patient does better. They're, you know, back to work 2 or 3 days, all done under local. I think it can be abused, number one. Number two, the problem is that the barriers to entry have been broken down, so anybody can do it. Previously, you had to be a surgeon to get OR privilege. Now you can do it in your office. And some of the insurance companies are reacting to this and trying to put qualifications on who can do the procedure. The state of Massachusetts, Blue Cross Blue Shield has restricted it to board-certified vascular surgeons
Is that right?
or to interventional radiologists. The way that the other insurance companies are getting around it is putting a premium on the vascular lab. You have to be a certified vascular lab, or now the SVS is contributed towards a organization which will certify venous centers. So it's not the physician being certified, it's the facility. Because it's the only procedure I know that in the last generation, 10 years, has grown in volume 400%.
Wow.
Versus the UK, which is relatively flat, where they have RFA, and certainly finances play a good role in why it has grown.
You know, Journal of Vascular Surgery is going to have a venous sister journal in venous disease. I think they should get you involved in it.
Well, I'm getting involved, certainly with the venous ulcer guidelines. And yeah, I'd like to be involved with it. I did not apply for the editorship because right now I'm pretty busy, even if I would get it. But I'm on the editorial board of the major journal. I guess they'll be using people from that. And it's a great idea. It accomplishes two purposes. One, it focuses on venous and lymphatic disease specifically and presents a journal that is headed by a vascular surgeon. Secondly, as I said to some of the editors, it decants the major journal so that more arterial and other cases can be published in the major journal. So it has a twofold beneficial effect.
Tom, you have tremendous experience in artery, venous, and now administration. What do you tell young guys to do when they come up? What's your advice to young vascular surgeons?
My advice to young vascular surgeons is go into it because you enjoy several things. One, dealing with patients. One of the things that I missed in administration was the interaction that we have with patients. And now that I'm back, it's nice to be able to sit down to patients. Two, the technical challenges of vascular surgery, even catheter-based, are very satisfying if you're, manually oriented, if you will. As far as the financial aspects of medicine, I tell the vascular surgeon, don't expect to make $1 million doing it. Enjoy the fact that you are doing it. What we're seeing is more and more vascular practices being purchased by hospitals or physicians working for hospitals, and that's the major trend. For several reasons. One, there's a guaranteed income for the vascular surgeon. Secondly, the hospital can use some of the technical revenue brought in from the vascular surgeon to sort of supplement his salary if he's employed. That can't be done if he's working with a medical group because that individual from a corporate point of view is not directly controlled. So there's a big movement to physicians working for hospitals.
Well, coming back to our experience in overseas, it seems to me right now there's a decrease of international exchange.
You're right, and I just think that young surgeons want to get out into practice. When we were training, you and Bill, as I look back at it, I spent 2 years in a research lab, 2 years with the military, and then a year in England, and then a year with Clem Darling. Actually, my first job I was making at Tufts, I was making less money than when I worked as a fellow at the Mass General and did some moonlighting. So I think young surgical residents want to get out and practice, pay back debts or whatever. They want to get through things. But certainly they don't have the military obligation, and many of them don't do laboratory research, so they're finished pretty promptly, 7 years. They don't want to take that international step, which I think is great for you and also for your family.
I really enjoyed my time there. I'm sure you do.
Oh, I've made many friends, and
True.
I try and get back and at least see them at major vascular meetings. The Europeans have been very good in supporting the SVS and Frank Feast meeting in New York in November.
How's your tennis these days?
As I said to Bill, I had to give it up. I used to just knees and backs, and then an Achilles tendon tear really knocked me out. So I'm stuck to golf, but I remember our matches in Maui. I remember playing with John Oxner in New Orleans in the heat, and he would not stop for anything. On the rooftop of the Hilton, we had these matches.
We played with Gene Stranis.
And Gene Stranis, one of the great features of our vascular meetings, be they the major or the regional, was an opportunity to play with all of the fellow vascular surgeons, Roy Taz.
We had a good time.
Yeah.
Tom, thanks for coming for the interview.
Well, thank you and the Society for asking me out. This is a real nice opportunity. And as I said in my email to you, I'm facing my 50th reunion at Harvard next year. So it's been able to allow me to put my life in perspective, perhaps to write a class report. So Thank you.
We can show your interview in your 50 years.
I think there are more important people than me in my class. Thanks.
Thanks for coming.
Thank you.